So first, I want to say thank you all so much for joining us. Really excited to have you here and being a part of our spring icon event. If you've joined us before, you'll notice that we have a little bit different things happening this time around. We didn't make you choose to go to one or the other. This time you get to go to both, all of the things. We heard your feedback. We are listening, and I did give you a 15-minute break for lunch if you're going to be with us all day. So we are definitely listening. Before we go any further, it is my pleasure and honor to introduce our CEO, Greg Lee. Greg has been with the foundation for over 15 years. He is a 3-time cancer survivor, and he is our fearless leader. Greg, the gallery is yours.
Thank you very much, Suzanne, and welcome to this Icon Spring Summit. At Livestrong, we are now celebrating our 25th year, our 25th anniversary. Literally just started here just a few months ago. And during that time, we've been so fortunate to be able to reach more than 109 million people. We've served a little over 12.2 million people, and we've saved that group a little over $91 million in direct healthcare related expenses. We all know that living with cancer isn't easy, but it doesn't have to be so hard either. Because of the efforts that you have and the work that you're helping us do, we are all about finding new solutions to those old problems to try to fix them for good. And just as usual with our Icon Summits, that's why we're here today. Today, we're going to tackle gaps in care that exist in 2 critical areas. One of those in transportation. We all know that if we get people to their appointments, they have a better chance of success. They have better outcomes. The challenges exist is when they start skipping those appointments, skipping chemotherapy sessions, skipping those things. And there's a number of different reasons. We're going to explore that today and try to find solutions. We also know the challenges that are associated with end of care or end of life care and the challenges on that last slide. And we want to be very sensitive to that, but also try to identify solutions that will make that emotionally and physically challenging time better for everyone. We're also going to conclude our sessions today with an announcement of our 2022 Solution Grant Award winners. In our history, in our 25 years, we've had over 600 partners that we have helped fund and grow programs together. And we're excited about what that looks like and look forward to the announcement later in our programs today. Thanks again for joining us. You didn't come to hear me talk. Let's all make it a great day and have a phenomenal Icon Spring Summit. Suzanne, back to you and the team.
Thank you. Without further ado, I want to introduce our very first speaker, Winora Johnson. Winora is a 3-time cancer survivor. She took her experience in cancer and she's turned it into advocacy. So she is passionate about making a difference, passionate about changing the outcomes for everyone. So I want to introduce to you Winora Johnson. Winora, the gallery is yours.
Thank you, Susan, for that introduction. It's so much appreciated. And I also wanted to give a great shout out to Greg and Susan, both of you, just for inviting me to an opportunity to talk about what's important and hearing the patient's side of what we go through when we are diagnosed with cancer. So Susan, if we can go to the next slide, please. So again, my name is Winora Johnson. I'm a 3-time cancer survivor. I'm a Navy veteran. And as Susan mentioned in the very beginning, I'm a very passionate patient advocate. I'm actively involved with various organizations who promote changing policies and guidelines, educating patients about clinical trials, genetic testing, and cancer survivorship. And cancer survivorship comes with understanding what we're going to be discussing, which is transportation needs. So next slide, please. So if I can share with you a little bit about what my story is and what I faced in 2011, that's what you'll hear a little bit about. So after a yearly checkup with my primary care physician, my doctor asked me to take a fit test. That fit test led to a colonoscopy, then surgery, and waking up from surgery and being told I had stage 3B colorectal cancer. I also had genetic testing done, which identified me as being Lynch syndrome positive, and since then had two additional early stage cancer diagnoses. Today, I have no evidence of disease, and I'm thankful for that. But one of the major components of me being a survivor actually had to do with my transportation needs. While I had a full-time job, healthcare benefits, and a vehicle, I still had to travel multiple times throughout the week for treatment and follow-up appointments that can take a toll on you mentally and physically. Many times I had to ask family or friends for help because I didn't feel physically well enough to drive. And while I've gained my health back, I'm still under regular surveillance with my doctors, which require time off from work and traveling to various physicians for my follow-up care. Now, prior to my own cancer journey, I was a caregiver for other family members who passed away from cancer. And currently, my brother has also been diagnosed with a late-stage colorectal cancer. And while their transportation needs varied, I remember at one point when I was caring for my mother who had a glioblastoma cancer diagnosis. She lives far enough away that I actually had to just physically move her to be near me to make sure that she could receive the treatment and her needed care. And again, that took a physical and mental toll because, I mean, it's your mother. You want the best care for her. And it all centered around transportation. The pandemic itself has made it even more challenging for care and treatment, especially for my brother. I'm a virtual assistant caregiver for him, meaning that I'm reaching out to his healthcare providers with concerns or providing him with questions to ask his doctor about his care, and even ensuring that he gets appointments, gets to get to his appointments using a rideshare service. And this can be challenging, especially since I have a brother who has a mental health condition and currently lives in a supported living facility. And a lot of times they just don't have the needed transportation for them. And it's very challenging. And again, it goes back to that mental, physical, and emotional draining of being a caretaker and a provider, because you're constantly worried about their life and how they're going to get their care. And as you can see here, I put a quote in this particular slide from the American Cancer Society that states, every day, thousands of cancer patients need a ride to treatment, but some of them may not have a way to get there. So what we need to address is how we can assist these individuals and help them sustain a quality life free of this particular worry. So next slide, please. So transportation needs of cancer patients are often overlooked. Those concerns for patients become the travel distance, lack of access to a private vehicle, or the option of riding with others, trip frequency and trip length to a healthcare provider. And those transportation needs vary when you live in a rural area or an urban area, but they can still take a toll on a patient who struggles to figure out their finances to incorporate the higher prices of fuel or an income that just doesn't keep up with the cost of living itself. So next slide, please. So this is a picture of myself and of course a picture of my brother as he was diagnosed with colorectal cancer. And it's going to talk about three different things here. One is that transportation barriers have a profound effect financially, social, and psychological impact. And if I go back a little bit to the financial impact, for me, it was taking a lot of time off from work, always worried about how my coworkers or my boss will feel about me constantly leaving for work, or if I would lose my job over it. And then it's just the distance to and from treatment. I mean, even though I was treated locally and I had that option to be treated by my local oncologist office, it still was at times a burden to try to get there when I wasn't physically feeling well. And when it comes to productivity from work, if I were to quit, I would probably no longer have affordable healthcare insurance. So that drove me to keep working on a full-time basis so that I could have appropriate care. And the cost of care, for me, for instance, just the 3 months of treatment came for my colorectal cancer when I was diagnosed in 2011, came with a price tag that was over $350,000. And while, yes, I had insurance, the copays were still just as pricey. And that's just the financial side of it that, as a cancer survivor, you look at. But then comes the social and the psychological impact, the mental well-being part, where you're always worrying about, should I bug others and ask them to maybe take me to an appointment? Can someone else share a little bit of the burden for that? And sometimes we just feel like others truly don't understand what it's like to go through a cancer diagnosis. Cancer can strain relationships with family, friends, coworkers, let alone affect our quality of life. And treatment and side effects have an enormous impact on us. So for me, developing neuropathy made it hard to drive, or it was excruciating pain. So that's just some of the psychological impact that stays with you. And because I was identified as being Lynch syndrome and having probably additional cancers throughout my life, this is something that never goes away from me. It's something I constantly think about and sometimes worry about. Am I putting a strain on my family? But this is where the benefit of emotional support can come in through counseling, a support group, or maybe in your faith community. Now, cancer is a chronic illness, and even after treatment is completed, continued care to have a good quality of life involves transportation. So for me, my surveillance for the rest of my life is every 6 months, I am visiting at least 6 to 7 doctors. And that it takes a toll. So how can we address that? What if I lose my vehicle? What if I have an accident and there's no one around to take me? Those are constant worries. Patients, particularly minorities, may opt to forego needed care when there's no available and affordable means of transportation to treatment facilities. These findings demonstrate that the need for healthcare providers to be aware of transportation problems that patients with cancer experience in obtaining treatment is important. So having that empathy from a doctor and those outside that circle really understand what it's like as a cancer patient that we worry about transportation needs. Healthcare providers must work with patients, their family, volunteer agencies, and the community to facilitate transportation needs to cancer treatment for patients. So if I can go to the next slide, please. We need to truly understand the importance of transportation, accessibility, and their relationship to cancer outcomes. Because for some individuals, it becomes a matter of life. And so I want to thank you for listening to my story and some of my struggles. And of course, I'm open to any questions you may have or suggestions as well.
Thank you, Winora. We've got just a few minutes. If anybody has any questions, thank you for sharing your story. I was so excited when she agreed to speak with us today because it's hard to be transparent when you've gone through so much, and she's traveled so much and endured so much as an individual, not just fighting her own cancer battle, but many loved ones as well. Does anybody, a lot of people on this call are program directors and executive directors, managers, people who are just as passionate as finding solutions for transportation as you are, Winora. Is there anybody who's got any questions before we move on? Julia.
Yes, hi, good morning, everybody. Good morning, Suzanne.
Morning.
Thank you, Winora. Really appreciated that perspective. I'm just wondering, did you get any kind of support or guidance at all from the hospital systems?
You know, Julia, it's interesting that you even say that. I guess sometimes as a patient, when you're diagnosed with cancer, you're so focused on living that sometimes you don't even think to ask. And I think because hospitals are so used to just treating the patients that they don't even assume that the patient even needs such a simple answer or an ask. And when I think back, that probably would have went a long way to helping me mentally continue to cope with a cancer diagnosis if someone had have just even said, hey, there's these old organizations or programs that could help you with transportation if you need it. And it, believe it or not, it wasn't until even 2 or 3 years ago that I even knew my oncologist office had a nurse navigator. I'm going, wait, where was she? I'm still being treated there. I never knew this. And this is just some of the things that get lost by patients as we struggle just to survive.
Great. Thank you, Winora. All right. Well, now comes the time where we are going to ask you to be a part of the solution. I have the honor with working every day with KK McCaslin. She is our Director of Programs and Community Initiatives. She does a lot more than just that. I think her title should be much, much longer. She is the lead for our cancer survivorship activities. Primarily, she's focused on the delivery of direct services and community programs, stakeholder engagement, and strategic evaluation. She really helps us determine where the money goes and how we use it. So KK also has an MPH. She is a skilled moderator and setting you up for, it's all going to be great now, right? Okay, so KK is going to lead you in a discussion. So this is that time. Take off that mute button. We're looking for gaps and we're looking for solutions. KK, the floor is all yours.
Thank you, Suzanne. Good morning, everyone. It's nice to see some familiar faces as well as some new names on the call. Like Suzanne said, I've been with the foundation for 4 years and I touch all of our survivorship activities. And it's really my job to help us solve everyday cancer problems today. So I'm really excited to talk about transportation this morning. As we know, it affects everyone in the healthcare system. So to tee us up, I'm going to read off a few statistics that I found when I was prepping for this conversation. And the numbers really surprised me. So we'll see how you all feel about them as well. Currently, 3.6 million individuals do not access medical care because they experience transportation barriers. Regardless of insurance status, 4% of children in the US miss a healthcare appointment each year due to unavailable transportation. Transportation barriers are the third leading cause of missing a medical appointment for older adults in the US. And missed appointments and resulting delays in care cost the healthcare system $150 billion each year in the US. So obviously this is a far-reaching issue. Looking at the bigger picture, research has shown that only 20% of health can be attributed to medical care, while social and economic factors like transportation account for the other 40%. Transportation is necessary to access goods, services, activities, whether that be emergency services or healthcare, or just going to the grocery store or getting food, going to work, going to class. So overall, transportation touches many aspects of a person's life, and adequate and reliable transportation services are fundamental to healthy communities. And I think Winora touched on many of the gaps that exist from the patient perspective, as well as providers and other people who are involved in the delivery of cancer care. So I just want to open up the floor and see where people think we should start. What do we think are some of the gaps that exist in transportation? Does anyone want to start us off? Let me list off a few and we'll see how everyone feels about that. Common transportation barriers include long travel distances, lack of vehicles, the cost to use transportation, inadequate infrastructure, and policies affecting travel. So has anyone experienced any of those or is familiar with some of those from being a caregiver perhaps?
Dave, I see you off mute. You're following the rules, so I'm calling on you.
Okay, I think I'm the real outlier on this call because I'm actually the retired CFO for the Council Michigan Foundation. So we were a membership association of foundations in the state of Michigan. So we didn't deal with direct care for cancer patients, but a lot of our members did. So I'm just on the call to kind of hear what this is about. I actually visited the Livestrong Foundation, I think it was about 10 years ago when my daughter was living in Austin. But so I don't have a solution, but what's interesting is my healthcare provider is Spectrum Health here in Michigan, which is a large provider. And I would say about 6 months ago, they started asking a lot of questions about financial needs and transportation and stuff like that. And, you know, of course, that's not something that I need. And I kind of thought, well, this is, you know, it's nice they're asking this. I wonder with it. But so I guess what I would say to this group is transportation is one of the questions that Spectrum Health ask about. And I don't know what they would do depending on how you answer, but my assumption is they have some solutions. And so that's new. I think they started that about a year ago. And so I think that could be a solution where the healthcare providers should be asking those questions, and hopefully they have somebody they can send you to if you check a box and you have a need. So I just wanted to mention that at least one of our big providers in Michigan are starting to at least ask the question about those needs. So I thought that was kind of interesting that they're doing that.
Absolutely. And we can definitely bring that back to the forefront when we get to the solutions part. I saw Scott come off mute a long time ago and then raise his hand. So I'm going to go to Scott next.
I don't know if my experience is common or not, but you spoke about the long distances to treatment as an issue. And most of my cancer care could be provided at my local hospital, but at one point I needed surgery where the expertise was an hour away. And as soon as I went to have that surgery, they expected all of my follow-up and all of the things that needed care after that to stay at that facility. And it was up to me to say, you know, my local oncology center can handle some of these things. Can't we have some of these things that, you know, only take 10 minutes in the office to handle? Can I do them where it's convenient for me? So I think sometimes the answer may be eliminate the need for the travel.
Yeah, I would agree. And studies show an association between poor health outcomes and how far the patient lives from healthcare facilities. And this is evident at all levels of geography, both local, urban, and rural. But obviously, if you are rural, distance, time, and lack of public transportation are definitely heightened issues. But yes, we'll also bring that up in the solutions discussion and how telehealth and other things like that, coordinated care, are playing a positive role in eliminating that transportation issue. I'm going to go to Winora next because I think that was the order. Go ahead, Winora.
Thank you, KK. And Scott, I really appreciate you for mentioning a portion there of your story. And I love your shirt. Would love to have one of those shirts. But I just want to mention, especially, you know, from the patient's voice, that it's such a concern for us of worrying about transportation that sometimes you don't even realize that it becomes a worry. You're so excited maybe about getting that appointment with that specialist, and then you worry about the transportation part. So if transportation itself or that discussion can be part of the discussion when the initial cancer diagnosis made, when that individual sits down with their doctor and it becomes part of their care and treatment plan, maybe that can alleviate just some of the concerns about missed appointments that arise, and a patient will be less reluctant to approach their doctor about that concern.
Yeah, and Winora, we experience that a lot through our navigation program. I know Kim is like nodding her head right now. That's one of the first things she hears about when a patient calls in. You know, they may mention financial, and transportation is a close second. So I agree, incorporating that into navigation services could make a really big change. But, you know, it's like, why does the patient have to ask? Why is it not just brought to the forefront? Next, I'll go with Julia.
Hi, this is so pertinent for me to hear all this. I'm Julia, everybody, and I run an organization in Los Angeles called the Cancer Support Community, and we have free services for cancer patients and families. And we hear this all the time, what Winora was saying, that, you know, you're fighting for your life, you're fighting for your health, you don't know what questions to ask. And so if this was just happening at the point of diagnosis, I don't know if they told you that they even had psychosocial support at the hospital. We're very connected to the hospitals in our area, and we work with the social workers throughout the city, and they refer to us all the time that there's a gap in getting patients from their doctors to the psychosocial support that they might need and want. And something that we do is we have a distress screener. So anybody who comes to our organization does our validated distress screener of about 15 questions. And one of the questions on there is transportation, because that's a source of distress. So we will find out that a person has an issue with transportation and then try to connect them to the resources they need. But you're so right, Winora, and Dave, you mentioned this too. You have to ask the questions and really be there for the patients and the families and help guide them. There's too many other things on their minds. So you got to ask the questions and make the connections.
Yeah, and that's really awesome that the hospitals you work with, Julia, have it as a line in the distress screening. But I think we all know it may be one.
No, we do. They don't have it. We do. The cancer support community. I mean, they might if they have a distress, but we have our own distress screener that we made and validated for the cancer support community. So I'm not sure what all the hospitals do. Sorry to interrupt.
No, that's a great point. And I think that's interesting because even if it's a full section or, you know, one line in your screening, we all know that it's a basic need that leads to a lot of other problems. It's one barrier that is a much larger barrier for other things. From my research, it says transportation disadvantaged patients are at risk for many downstream health challenges. That could be delayed or missed appointments. It could affect how well you manage your chronic disease, whether that's cancer or not. And you don't really get that opportunity to prevent future issues if you're not having consistent health maintenance. It can make it difficult to diagnose something early on. I think we all are aware of that. And it can also lead to more costly emergency department visits or hospitalizations that could have been prevented if you were able to consistently go get your medical care. So excellent point. I'm going to pass the mic to Anne-Marie.
Hi, everybody. Anne-Marie Morides. I'm actually a postdoc fellow doing research in young adult cancer care. I'm just listening. I'm originally from Rochester, New York, and their YMCA, of course, has medical offices, which is really just such a nice opportunity. I don't know if it's certainly not the standard where I am here in Massachusetts, but I'm, listening to Winora talk about obviously acute visits, and I'm thinking, is there, a volunteer group of people that could be utilized, and with Livestrong kind of helping to oversee that and screen that. And then of course we have to harness in our post-COVID the use of telehealth, and perhaps in our rural communities where connectivity is an issue, places like the Y, whether it be a brick and mortar or, an outstretch of the Y, may be interesting to provide location and equipment to foster some privacy should a patient want to consider that. But I'm also listening to some of you speak about the wonderful use of the distress screening, and as a nurse and an exercise physiologist, I think one of the problems that I see is just this communication loop back to the provider to really harness everybody in. And I know from my friends who run the, Livestrong here locally, as a nurse, I've kind of been informal when they've had, drug questions or questions like that. But I see just a real lack of continuity of transferring of some of the wellness-based care by a lack of communication. And as I listen to you talk about this distress screening, I wonder if peripherally, as we address these transportation issues, we may, and end of life care, by the way, we may want to see how we could open up those lines of communications to make them bi-directional and have more people trying to solve the problem.
Yeah, and it looks like Stephanie also made a comment about the screening. Distress screening is essential and should be done at every cancer center. As an oncology social worker at our main center in Vermont, we have a patient navigator who addresses all of the patient's transportation needs. We have been very fortunate to have been able to retain her after ACS had to cut their PN positions across the country due to COVID. So they saw her role and her efforts in transportation as essential, and I'm really happy to hear that. I'm going to pass the mic to Heather.
Good morning. Thank you, KK. I'm really excited to have this conversation about this is an area that I've been a cancer advocate and cancer survivor for 25 years. And I feel like transportation has been just an ongoing conversation. I actually live in Southeast Michigan. And so as Dave can probably attest that we do not have great public transportation here. I don't want to slam our transportation, but we probably will never have great public transportation in Southeast Michigan. So that's always been a challenging. My current job, I actually work for the largest physician organization in Michigan. And this is great timing for this icon because we have been working the last couple of weeks, really working with our doctors to bring social determinants of health and the major importance of having these type of conversations with the doctors. We're working on educating our doctors on the importance of this so that they can make it be seamless in their conversation with their patients. They can let their patients feel very comfortable sharing it. So I'm excited for this because I think that is a really important avenue because many of our doctors do want to talk about it, but they also don't know what they're supposed to share. So we've been partnering with the organizations and, putting together a toolkit. So I'll be really excited to see if I can tap even more, resources and organizations to work with because the cool thing is also the insurance companies, which might be why Spectrum and different health systems are starting to ask the questions. Insurance companies are starting to look at it also and recognizing the need to get people in for their medical care, to be preventative, to be proactive. And they're looking at incentivizing doctors to be having these conversations, which I personally feel is a win-win for everybody to have the conversations become a normal process in the patient provider appointments. So I like this. This is exciting.
Thank you, Heather. And then Anne Marie, this is great, Heather, and the public health nurses, APRN, tend to be very attuned to these issues and should be included in the conversation. And this is going back to something that Winora touched on. Just because you have a car doesn't mean you have transportation. So using the term from the National Center for Transit Research, being transportation disadvantaged means more than not having access to a personal or shared vehicle. It can mean having a vehicle, but not having money for gas, parking, or permits. It can refer to living in an area that isn't well served by public transportation or doesn't have the infrastructure for safe walking or bicycling. You can be transportation disadvantaged with access to a vehicle, but live so far away from healthcare resources that the distance makes accessing them difficult or impossible. So I think it's definitely not a black and white type of issue that's going on. And like I said earlier, it leads to a lot of downstream health challenges. So has anyone experienced that? I know Scott kind of touched on it, or seen it in your healthcare system or where you live. I personally grew up in Portland, Oregon, and we have great public transportation. So I hadn't really thought about this issue. I grew up above Oregon Health Science University. If I was downtown, I could take the MAX anywhere. So I hadn't really thought about transportation until I was in a small town in Southern California and now here in Austin, Texas. But I think it's very interesting to look at the different landscapes and kind of recognize that there's not a straightforward solution, which is why this conversation is so important to have. I'm going to pass it to Winora.
Thank you again. Sorry to keep jumping in here, but I also want to mention the fact that I served as a Navy reservist, and one of the things that I thought was great that the military provided was a healthcare system that was reliable. But when I saw what I experienced as a caregiver from a husband who passed away from pancreatic cancer, who was just crazy. I mean, you have a veteran that has to travel 2 hours to the nearest veteran center to, first of all, get diagnosed, and then the constant back and forth to travel back and forth. So the caregiver is just as affected, or the family member, whoever's taking the individual and using their vehicle, even if they have a vehicle. It's like I said, it's a barrier, it's a burden, and it just becomes that worry that again the patient takes on too, to say, well, why is it worth living if I'm putting my family through this constant stress? So I guess my main point of all of that is just to say that even if a person has a healthcare provider like through the military or something, there's still large barriers there that prevent people from following up with their doctors and canceling those appointments that sometimes need double referrals just to get to.
Yeah, that's a really great point. Suzanne, did you have a comment?
Yeah, I actually was going to, I actually wanted to mention Doug's comment in the chat. And Doug, I think you had a really interesting point where you were talking about, you went to, I wondered if you could talk more about the hospital cancer care in the difference between what you heard at one location and what you heard in your hometown.
Oh, well, I was down at Indianapolis at I used Salmon Cancer Center for the last two and a half years almost. And then I got a phone call in end of January this year, and found out I couldn't, without going into details, found out that my medical oncologist could not handle my cardiac and my cancer issues. So he transferred me. He referred me to a Fort Wayne Parkview Cancer Institute. So there was like 100% difference in care. In fact, they offered palliative care almost, immediately. And they talked about, social workers. And I mean, yeah, it's closer. I have no transportation problem. I drove, 2 hours, 2.5 hours down to Indianapolis every 3 months. But in a way, it turned out good, but I didn't get the same assurance from, I wasn't treated as a whole cancer patient. I'm not sure if I'm saying that correctly, but maybe you can help me a little bit. So since February of this year, I'm getting treatment in Fort Wayne, and it's a whole big difference. So thanks for letting me share a little bit.
Yeah, well, thank you for sharing, Doug. And I hope you're staying on all day, because we're going to be talking about palliative care this afternoon.
Oh.
Well, now you know.
What time is palliative care?
It starts at 12:15.
Okay.
Okay, Central Time. But that's a really good point. There's one thing like getting to your appointments. What is the quality of that care that you are traveling to? Certainly something to consider. And is it worth, going that extra distance? And also, yes, treating disease versus treating the whole person is something we definitely notice at Livestrong. We're very aware of whole person needs, and that's something we try to keep at the forefront when we address cancer. And kind of something that's been coming up that maybe hasn't been said directly yet is transportation problems reach beyond making medical appointments. It's also essential to going to the pharmacy to fill a prescription or obtaining imaging or laboratory services. It could even be going to the park to get some exercise, get that sunshine, enjoying the green space. So really, transportation is a vehicle for wellness in the big scheme, and as you're going in and out of treatment, and developing affordable and appropriate transportation options, walkable communities, bike lanes, bike share programs, and other healthy transit options can help boost health. Anne-Marie, I know you've had your hand up for a while, so I'm going to pass it to you.
Oh, no, I appreciate the wonderful conversation. Doug, I'm not going to be here for the palliative care either, but I appreciate you talking about the quality of care and the whole person. You articulated that very well. And then Winona, I had the fortune of driving a friend. There was a few of us, over a 4-year period where she had treatment during her palliative and then metastatic stage. And I resonate with you because it was always a struggle. She felt like she knew there was, better care in Boston. It was an hour drive. The way her treatments were set up was, 8 hours. There was, medication given that would make her groggy. And yet for all of those 4 years, even though we had, surrounded her, there was guilt that she had, regardless of what we said and tried to minimize, like, we want to be here for you. We want to do this, but it was hard for her. And yet, for her, she wanted to watch her youngest graduate from high school, and she wanted to kind of make it to that point. And so we were going to rally for her to do that. And so I didn't feel like it was caregiver burden for me, but she felt, and I can appreciate that. We want our independence, but there's no way she could have even taken public transportation when you're, receiving medicines for some of these treatments that, make you groggy, and there's no way she would sleep the whole way home. So I think we need to kind of consider what type of care, and there'll be more than one answer as we try to address these transportation issues, right? It won't be one answer. But I do also want to say, KK, I love the why, body, mind, and spirit. I got my master's from Springfield College, which is the original why teaching. And I think what's so beautiful about the Livestrong program is they do really give a human side to the person, and they focus on their strengths. And I think it's just an incredible benefit.
Oh, well, we're really glad to have you here today, Anne-Marie. So thank you. And I see the comments in the chat box, and I'm going to come back to them and pass the mic to Julia.
Thanks, KK. And like Winora, I know I'm talking a lot, so feel free to pass over me if you need to bring someone else in. But it's just such a great point that Winora brought up about having a car, but maybe not being able to access or be able to use the car because what Anne-Marie just said, you're groggy, or whatever is going on, or it's expensive. What Heather just wrote about, it's expensive to park in the hospital too. And those of us who are of an age where we're having colonoscopies, they tell you have to have a ride home. So imagine all the things that cancer patients are going through with medications and not being able to actually drive their car. So it made me think about something at our community where people help each other, who are in groups together. They take each other to appointments. And I'm going to go back to the team. We've been talking about an alumni group, the people who are past treatment. And maybe this is something that they could do for the rest of the community. We could have some sort of formal system in place where folks could help other people who are in the thick of their treatment, who need that transportation, and they just simply can't drive because of the medications, et cetera.
Yeah, that's a really good point. And I love all these comments about financial needs, because I think it's going to be the perfect transition to our solutions discussion. So I'm going to read through these really quick. And also wanted to mention that Scott said you may not feel well enough to drive, which is a good barrier to acknowledge as well. So from Heather, when I went through treatment for my first cancer, the hospital charged for parking. We were there all the time and it became so expensive: treatment, blood work, tests, appointments, etc. My parents worked with the oncology department to lobby the hospital to provide free parking to cancer patients and caregivers. A few years later, the hospital moved to free parking for all patients and visitors. Amazing. I'm not surprised, Heather. That's fantastic. I wish that everyone did that. Parking is so expensive. Winora gave a kudos for your advocacy. And then Sarabi, from a policy perspective, health insurers should cover transportation to ease some of the financial strains, maybe partner with rideshare services like Uber Health, Lyft that work with hospitals and health systems. Medicaid, for example, covers NEMT, but I don't think Medicare does. So we'll definitely talk about the potential of ride sharing. We'll also be hearing from a speaker later today who's kind of leveraging that in their local health community. So to tee us up for our solutions discussion, but also acknowledging the gap, transportation can be unaffordable. Vehicle ownership, cost of insurance, fee, train and bus fares can be expensive. Individuals with transportation barriers are more likely to have low incomes and high expenses. Data from the Bureau of Labor Statistics shows that people earning between $5,000 and $30,000 a year spend 24% of their income on transportation. So a quarter of your earnings on transportation. Alternative transportation options such as bike sharing or ride sharing programs require you to have a bank or credit card account. So if you're unbanked, it may not be a suitable option for you. So we can start with financial, or we can start with hospital systems, but what are some ways we can begin to chip away at this problem? Does anyone have any ideas? I know we heard some very early on, but now that we've kind of talked about the issue more comprehensively, is there any first steps that come to mind? There's no wrong answers, so we're just noodling here.
Okay, I would love to see an app or portal created where if you're in any state that a patient or someone's reaching out for, hey, I need help here in Illinois, can I get immediate access to an appointment on such and such date or something like that, that kind of talks to everyone, or, or to, all organizations have access to that portal. So at any given time can pop in, well, I know who does such and such, and just a great networking opportunity through an app. I'm sure something like that may be a little challenge to invent, but I mean, that's what innovation is about, creating something that works for everyone.
Yeah, and I think even if those do exist, because Livestrong has been approached by saying, can you add our resource to your website and this and that, but it may not be scalable yet. The reach might be so specific or just at one hospital. And it's great that each hospitals are making progress, but that's not going to solve the 50 state issue that's going on. But I love that idea of a portal where there's interactions between providers, patients, all the relevant players to help tackle away at this problem. I'm going to pass it to John.
Hey, thanks. I don't want to talk too much because
before you talk, don't give away okay.
I just wanted to say that one of the things I learned, and actually Livestrong helped me learn this. So I'm a physician and I worked in the cancer care world in a cancer center. And what I realized with trying to make differences from inside that center is if you want to be patient-centric, you will never do that from inside a healthcare system, period. End of story. So what does that mean? It means you have to step out into the community and into the patient itself. And everything you build has to be patient-centric. And this is actually why I think Livestrong in particular is potentially the most important cancer patient advocacy group in the country, because it's the only system that is truly patient-centric. And what we do here and what we build here is going to be real solutions. It also means that we have to build them here as opposed to waiting for somebody else to build them. Because if it's built in the cancer center, I don't care what cancer center that is, it's going to be about that center taking care of you as opposed to you getting to the care that you need. And those are two very, very different things. So I'll stop there.
And don't worry, we'll be hearing from John in a little bit. And there's lots of comments on the side. So Ann Raymer, I know you mentioned earlier you're interested in equitable access to transportation for clinical trials. And I know I sort of tabled that because I think it's not just clinical trials. I think it's getting access to many things. But I like your idea of normalizing the conversation in the clinical setting with screening, transportation being one of those first topics that we talk about. Because like I said, Livestrong, it's pretty much the second topic that comes up after financial needs when we receive navigation cases. And Heather, do you just want to speak to your comment really quick?
Sure. What was my?
I know, but I'm trying to follow along. Change of perspectives.
Oh yeah. So I totally agree that so what we've learned with our doctors is working with, again, doctors in Southeast Michigan, they really want to have their patients share because their perspective is we can't fully care for our patients if we don't understand what the barriers are to them getting care. And rather than them thinking that these are non-compliant patients because they're not taking their medication, they're not showing up for their screenings, they can't figure out why they're not taking advantage of what these doctors are sharing with them. Many of them want to know these conversations. On the flip side, though, not all doctors are, can come off as approachable. And so that's, again, like what my organization is working on is helping them have the tools and the resources to be able to not just be open and have a patient be comfortable, but then in turn say, I hear you, I hear your challenges. Here are the resources that we have for you to be able to provide it. I mean, the reality is in medicine, those of you who are in medicine, I mean, it's not just taking care of the patient's medical, it's making sure that it's a well-rounded area. So that's kind of where we're looking at it from the provider perspective, because it's one thing for the patient to feel comfortable sharing it, but then if the doctor's like, okay, that's great. Anyway, let's move on. We want them to be able to have the resources to do it. But I think it's going to take a massive shift in healthcare, quite frankly, to do it. I mean, I've been a patient and I've been, working with doctors now, and it's a very interesting dynamic and perspective. But so hopefully having the insurance companies start stepping up more and doing different things might help also, but we'll see.
Yeah. And then Anne Marie, you made a great comment about stakeholder engagement, whether that's stakeholders you pick or stakeholders you need. Would you want to bring a little more light to that?
I agree so much with John and what Heather said. And being in the healthcare, being married to healthcare providers, it's unrealistic, especially because there's a shortage of, it's unrealistic for us to put this on physicians. And in my dissertation work, I was looking specifically at physical activity integration for young adult cancer survivors to take care of some of their psych oncology needs. And the providers were saying to me, like, we're not going to offer, these international, oncologists, we can't offer something that we can't provide. And I think that's really fair. And so, yes, they can note it, but to John's point, unless, the use of community participatory research is so huge right now, there's been so much progress in healthcare and certainly in cancer by using that. So, and I think Livestrong is, if we're going to do a spoke in wheel, Livestrong could be an essential spoke for the many wheels. They may not be able to do it all, but they're very respected in the community, and it is wellness and strength-based, and yet it's attuned to minoritized populations, to people who may have, other disparities that they're facing. So I think the idea of getting involved and having Livestrong be a central player as a stakeholder in community-based participatory research to answer this, we may hit our target better with less tries of trying to take care of these issues. This has been such a pleasure. And unfortunately, I'm a postdoc, so I have mandatory meetings all afternoon, but I look forward to hearing the rest of the recording and being in touch.
All right. Thank you, Anne Marie. Yeah, I mean, of course, Livestrong wants to be the great connector, but we can't fix every problem. But this report I read to prep for this, the American Hospitalization's 2017 report on transportation, really pointed out 3 buckets where we could all work together. And of course, it was written from the clinical perspective, but as our GAPS person, I really see it as a community-based solution that we could help and all come together to work through. So the first bucket that they described was providing enhanced transportation services. So how can we get patients from their homes to their physicians? So that may be enhancing public transit options. Maybe adding a new bus route that goes directly to the hospital or the healthcare center. Maybe it's providing reimbursements or vouchers for patients who use public transportation. Maybe it's adding multiple types of transportation. So maybe you can take the bus and the MAX or different things like that. And also ride sharing. There was one study that said ride sharing programs can help cut down on nearly $2.7 million that the government spends annually on non-emergency medical transportation. It also improves patient satisfaction by 80% because it's easy to use. But the reality is it's not sustainable unless there is a strong partnership between a health organization and a transportation organization. So has anyone dabbled in these areas or agrees with this idea or has a way to kind of solidify it? How can we get, in this first bucket, get patients to hospitals better? Any ideas? And if we don't like this bucket, we can move on to the next one. I think this is the hardest one and it's expensive, but I think it's good to talk about. Winora, go ahead.
I really like what and please forgive me if I mess up your name, but is it Surabai? They put a link about patient rising concert.
It's Surabhi, Winora, sorry.
Surabhi, I'm so sorry. So sorry.
That's right.
Thank you for sharing that information because this is what networking is about. There are programs or things out there that can help individuals when they're stuck in that mode. And this is what I'm talking about. It's all about sharing what's out there so that patients like myself, when I'm talking to someone, that I can even push them in the right direction. So I just wanted to mention that you put that in the chat and that it's much appreciated.
Heather.
I know that there has been some out there, like, American Cancer Society has a great ride program that I've had several friends. In fact, when I went through treatment a couple of years ago, I had several friends I didn't know they drive for ACS and they're able to do it. I know during with the COVID vaccines in Detroit, they did a sort of, creative program. And there's so many people in the city of Detroit that have transportation issues, but they wanted these people to be able to get the vaccine. So before they rolled out, let's say to the general public, they let people, if you volunteer to drive, pick up somebody who couldn't get it. If you volunteered, you actually got your vaccine early. So they did have quite a few people respond to that because people were desperate to get the vaccine. And then I also know that nationally, but we had several of our doctors take advantage of help their patients that the government partnered with Lyft to be able to, if you could get a free ride to get your COVID vaccine. These are all great ideas, but again, it goes, you kind of made the comment, somebody did that, it costs money, right, to do this. And even with ACS, they have great success with their program, but it also costs funding to do it. But I do like the idea of coming up with some creative ideas. I actually thought the Detroit one was kind of a very creative idea. They had quite a bit of success getting people to get their vaccines just by saying, because obviously people really wanted that part.
Yeah, so a different type of incentive, maybe not or voucher or reimbursement, you know.
Yeah, yeah. But again, like you said, it comes back to funding, and you have to make sure, people are aware of the program too, because I really wasn't aware. I thought there were restrictions even on the ACS program, and they're like, oh no, you can do this if you have to go here, if you have to go to the pharmacy, if you have to do this. And I was like, that's a really great thing to know. So I had then turned and shared it with quite a few friends who were looking for transportation help.
Yeah, and I think depending on where you are, sometimes rideshare programs will take you to your annual breast health screening or whatever it may be, but it may just be like a one-time thing where we all know you need to be doing that consistently over time. Yeah, so that's one bucket, maybe not our favorite bucket, and that's okay. So moving on to the next one would be offering community-based point of care. So rather than getting the patients to the clinic, can we bring the clinics to the patients? And that could be in schools, workplaces, primary care clinics, mobile clinics, home visits, all potential options. And then also telehealth when appropriate in the community, or somehow reaching homes if they have access to internet. It is a barrier to consider. Reducing the need to travel at all. So how do we feel about getting patients into the community for services? And does anyone have examples of that? Anne said a charitable option that could help defray rideshare costs might be developed, much as they do in grocery stores, to round up to help a cancer patient to get their appointment. So maybe that could be a direct funding stream or something like a bucket, like we've been saying, to really focus on and build up funding for that. Suzanne, do you have any examples about mobile screening? Perhaps
I do. Yeah. So, locally we have in Austin, we have the Big Pink Bus. I see Rayanne on this call, who is also participated and has a lot of clients who use the Big Pink Bus. Rayanne, I could share, but Rayanne runs BCRC here in Austin. I would love for you to talk about what your client, what the Big Pink Bus and that mobile bringing screening, right, or bringing treatment to the patient does for people you serve.
Well, thanks, Suzanne. I would love that. Our Big Pink Bus went silent when the hospital that had supported it for many years could no longer do it. So a coalition formed called Addressing Cancer Together here in Central Texas. And it was able to, with lots of 2 years of hard work, lots of grant support and private support from local donors, from support from our friends at Livestrong Foundation, we're able to reinstitute the Big Pink Bus. And so what that does is they schedule mobile mammography visits across the counties that we serve here locally. Most notably, they have been working in a small county called Bastrop County, and it has a high number of uninsured people there. And those uninsured people are able to schedule their mammograms on the Big Pink Bus. And the Big Pink Bus it got reinstituted last year, and they have discovered 2 breast cancers through those mammography services. And not only did the Big Pink Bus find the cancers, but they also provided, not the Big Pink Bus, but this coalition then provided the care for the treatment. We made sure that those women qualified either for Medicaid for breast and cervical cancer, or that there was private funding raised by this coalition that would then provide them the care that they needed to solutions for all cancers. Breast cancer was just the low-hanging fruit because we do have Medicaid for breast and cervical cancer, and we do have BCCS. And so those women who don't have access any other way can go to their local clinic, or go to their local church, or go to their local HEB, which is a grocery store here, a very famous grocery store here in Texas, and get the care that they need that way. And so it's a very unique model that is just going to grow and grow and grow and take on other cancers over time. So we're delighted that they have made such a big impact in our community, and we're here to support it in any way that we can. But Breast Cancer Resource Center actually provides patient navigation. And so part of what the discussion has been around is I believe that patient navigators belong in clinics and hospitals, either that or community health workers. And we don't get that opportunity necessarily here in Austin, Texas, as well as we'd like. We partner with them, but we're not co-located in those clinics and hospitals. So we feel like we can help solve some of those problems here locally regarding transportation and financial assistance, those kinds of things, where a social worker or a physician does not have to be involved. So I just wanted to point that out as well. But Suzanne, did I miss anything? Great, thank you.
No, that was great, Rayanne. And I think one of the main takeaways is you had the program before and then you brought it back bigger and better because you had all this stakeholder engagement. You had really discussed your target population. You were focusing on the underinsured. And I know the next step is a partnership with United Way to make this a true, consistently offered program.
They've hired their individual and it's launching, and I'm meeting with them in early April. So we're super excited about what we can do as a coalition, as a community, and a group of passionate stakeholders to solve these problems.
Yeah, and late stage breast cancer is a real problem in Central Texas. So it's definitely a point of need and a gap that your organization, along with many others, is helping to fill. So I'm going to look at the chat box. I know there's been a few things from Julia. One of the gaps that we've helped with is access to My Lifeline, which is a caring bridge, but for cancer only, in which patients can create their own support teams with calendars, etc., for what is needed, transportation and meals. So that's great, thinking beyond the household needs and thinking about transportation as well. And then pre-COVID, several of our large urology practices hosted community programs through Southeast Michigan focused on men's health screenings, education, appointment scheduling for tests. The programs were very well attended. So kind of when you bring the services to the people and they know about it, because like we said, getting the word out is a struggle with these types of programs. People will take them up. They'll use those resources if they're aware of them. So kind of going to our third bucket, which was interesting to me, I hadn't really thought about this, is expanding healthcare infrastructure. So what would happen if we had, specific appointment blocks that were outside of the standard 9 to 5 Mondays through Fridays? Would that help with transportation barriers or getting more people to appointments? Maybe those are early in the day or in the evening or even on the weekends. Maybe also restructuring clinics to help fulfill multiple needs in one visit, which is something that the Livestrong Cancer Institute is very passionate about. So, they can go in, see their doctor, go get a lab test done, do some imaging, but also fill their prescriptions all in one visit. Wouldn't that be a great use of time and maybe worth the transportation if you have to go out there? And that's just another way to reduce the burden on the patients and the time that I know Winora mentioned. It's just so much time for healthcare maintenance. So what are our thoughts on that? And is it feasible in our healthcare system and the way our providers offer care? Is it doable? Any thoughts? Physicians, non-physicians?
I think Livestrong has proven that it's doable, right? It's just the challenge of working away from the systems and environments that we're already entrenched in, particularly here in Austin, right? So you had to create a whole new model. Livestrong and Dell had to create a whole new model to make that successful in the midst of local oncology, community oncology practices. And so, so you've got to have the passion, you've got to have the vision for that. And then I'm sure it's still somewhat of a struggle for patients who don't know about you and are going directly to other, some of these community oncology practices, and they don't get the kind of wraparound care that you guys provide. And so, but I think it's doable, and maybe that, as we're talking about Livestrong being the spoke or the hub of the wheel, growing that model across the country might solve some of that problem.
Yeah, and I think we also get the benefit that our referral system is a little different. You know, it's like we're going to refer you to the person downstairs if we can. So we get the benefit of that. Suzanne, I see that your mic is off, so go ahead.
Yeah, I think it's the calm model is what we call it at LCI that Rayanne is referring to. I think it's a really interesting idea to be able to truly reach patients where they are and when they are available. The idea, John mentioned earlier that the solution won't be found within the healthcare community itself, right? What could we do to incentivize other healthcare organizations to change the model of work so that they aren't working from 9 to 5, but instead they work from, we can do infusions at 6 a.m. or we can do infusions or go see that appointment, that doctor at 8:30 when transportation could be simpler, right? When who mentioned guilt around providing that help as friends. I know my dear friend that I lost a couple of years ago now, she always said, I'm fine. I'm fine. I don't need anything. I'm fine. Well, she was far from fine, but it was that intense guilt. She had to take private planes back and forth from where she was in a very rural town to get care. So I wonder also if there's an opportunity to change the level of trust that people have towards their local providers, right? People always seem to think that you have to go to the big giant provider to get the best care, which I don't think is always the case. And I think we heard earlier in our discussion that wasn't the case at all. In fact, coming back home, he received a much better quality of care. So I wonder if that's an opportunity as well, is for local healthcare organizations that do offer great care to really do a better job of educating patients in their area.
And I know that there are physicians who intentionally carve out time to serve the underserved, whether that's like really early in the day or late in the day, or maybe they have an hour of telehealth that they keep available, from 5 to 6 or 6 to 7. So I don't want to say that it's not happening. I just don't think it's the norm, and maybe we should welcome it a little more. Julia, go ahead.
Yes, thank you. I was wondering what Rayanne was talking about because I didn't know about this calm model. So Suzanne answered some of that, but I'd like to know a little more about it. Is there a link that we can read about what that entails?
You bet. I'll stick it in the chat.
Great. Thank you so much.
You bet.
Yep, and it stands for Cancer Life Reimagined. So the link is definitely helpful, but I'm also happy to answer questions offline, Julia, if you have them. Heather, go ahead.
Well, I agree with you. I like the idea of having all of these appointments, in one sitting. I know when I finished my bone cancer treatment, 24 years ago, interesting enough, I went through pediatrics, even though I was 21, but they had set up a survivor clinic, back then. So every time I would go in, I would have an appointment if I wanted to, with a dietitian, with all my blood work done. Like they had all of these things, which was amazing. One of the challenge was that as I got further into my career, I was taking more time off, but at the same time, I thought, okay, it's annual, it's this, but it was great. So then when I went through treatment 3 years ago, I went through the adults and all that, and I will be upfront, like at the end of treatment, I was like, okay, where's my, post-care plan? Where's my survivorship plan? And she's like, okay, we'll just come back in 3 months. And I was like, whoa, no, like where I need to know this, I need to know this, I need to know this. And she's like, oh, sure, we'll put that together for you. And thankfully, I'd been through it, so I knew to do that. And it's just stunning to me that in 2022, this isn't common. To be honest with you, like it kind of throws me off that this is not a common practice for a lot. So I love the Livestrong. I love the Cancer Institute that you follow this. That's always been my big excitement when you guys launched this. And I think it needs to be more of a conversation that this is what we need to do to make it convenient for patients to have it all in one time and have everything right there. And we shouldn't have to ask as a patient. Thank God I knew to ask for it because now I can stay on top of my own care, but I shouldn't have to do that either. So I think that needs to continue to be the conversation also.
Yeah, and I think it's important to acknowledge for this conversation that it's wonderful to offer all the services in the same stop, but you still have to get there. So although it's maximizing your time and space when you're going and using clinical services, transportation is currently not written into the call model, but the benefit of the call model is less transportation. So just something to mention. So Robbie, go ahead.
Thanks, KK. So I just wanted to kind of go back to the point you raised about extended clinic hours. So I know that CMS, maybe about 6 or 7 years back, floated the oncology care model. And one of the things and the whole idea was to hold clinicians kind of accountable for the cost of care, overall cost of care for like an episode of care for a cancer patient. And one of the things that did work was extended clinic hours and weekend hours. And the other thing that I think I read about that model was partnerships with urgent care centers. So, an oncology clinic, and this worked, I think, really well in the community setting where they had these local partnerships with other service providers that help kind of rein the cost of care. But from the patient's perspective, if the clinic is not open at 7 and there's an emergency, going to the urgent care center that your clinic partners with was a really good option. I just wanted to kind of throw that out there.
No, and that's a really great point. A lot of people don't know that you shouldn't go to the emergency room for most things. You should actually go to urgent care, which puts a different type of stress on our healthcare system and our resources. So that's a really great point. But I just want to thank everyone for your contributions today, for both our gaps and our solutions brainstorm. I think it was very enlightening, and we had a lot of great perspectives, survivors, caregivers, loved ones, healthcare physicians, nonprofit people. So thank you, and I will pass the mic to Suzanne.
Thank you, KK. This was great. I want to let you all know, in case you're not sure, and I love the fact that I see so many new faces joining us today, and it's really great. The purpose of these conversations is not just to have the conversation, although that's great itself, right? But instead, this is the first step in what will be funding for 2023. So when we open our solution grants in 2023, we're looking to fund solutions. And we're going to be focusing on transportation. And that's why we started this conversation today. It's really important that we hear from you, that we understand what's happening in your local communities, and where can we and our donor dollars really make the biggest impact. That's the purpose of today. And the things that you've brought up are really eye-opening, and they're really great. Thank you all. So I'm really very excited to transition to John Salmon. John, who you've met, I'm sorry, I'm super jazzed, who you've already met. He is a practicing pathologist in Lynchburg, Virginia. He's been doing this for almost 20 years. He created Move Up with the goal of unifying into one single platform, enabling everybody to have better access to whatever it is that they need. And John has been a part of Livestrong for a very long time. And I recently had an opportunity. This is one of my favorite things about my job, is the more connections you make, the more people you meet. And every now and then people email me all the time. And sometimes I just can't entertain every single person that emails, but I try, I really do. And I am so grateful that I tried when John reached out. So John, I'm not going to give away any more excitement, but I want for you to share with this group a solution that you came up with because of the need that you saw. So John, I'll stop talking. The gallery is yours.
Well, I've waited a long time for this. Actually getting a little emotional. Can everybody see my screen? Okay. So, wow, yeah, this is a really big deal to me. I've been doing this a long time. So I'm a pathologist in Lynchburg, Virginia. I've been here for 22 years. I was the physician liaison to the COC for our cancer center. I ran our lung cancer program. I tried to develop a virtually navigated GI program. And for about 10 years, I've been working on a connectivity platform for communities. I saw it as a way to take technology and try to answer all the questions that all y'all are saying. I've been in countless meetings about this type of thing. So how can we build that solution? One of the things I learned from as being in the cancer center, as I mentioned, is that the solutions aren't going to come from there. You've got to go out into the community. It's got to be patient-centric. So I took a lot of these different things and I really tried to listen and build something that would work. So I'm going to try to, let's see if I can go to it. Does that still work? Okay. So yeah, this is me 4 years ago. I went to Livestrong. Greg Lee came to our cancer center because of one of my friends who were cycling buddies, and he's been very active in Livestrong, and really was instrumental in making all this happen, which is just amazing. I got to see everything there. I got to tour the cancer center before it was open. And even then, I was discussing, sort of how this would look, and I had begun working on the software solution that she mentioned. So I built an app called Move Up. And about 2 years ago, I actually resigned my full-time position as a pathologist to continue working on this platform. So now I'm more of a software developer than a physician, though I remain a GI pathologist at an endoscopy center, local endoscopy center, and where we're hoping to implement all of this. So Move Up is a connectivity platform for community. That blows everybody's minds. So there's a ton of stuff you can do with it. And one of those is transportation. So I've been compared to Uber like the whole time. Very much not Uber. The only thing that Uber and I share is we both have smartphone apps. Beyond that, there's nothing the same. So we can do a lot of different stuff. And the thing is, we have multiple different networks that we can intersect, and each of these things we've talked about is kind of, you're asking for its own network to be supportive of that particular process. And so that's really what gives it its power. And we can do things like deliveries from any kind of business, e-commerce, communication. But what we're here to talk about today is transportation. So we have this platform of transportation. I'll just tell you straight up, I've been to a lot of these discussions. I've been talking for a long time. I'm done talking. So everything I'm going to tell you about, this is all live, and we're beginning to implement it in our city as an example. And I'm hoping that we might use Livestrong to implement it in Austin as an example as well. So let me talk about transportation. This is a very complex problem. We've already heard that. And what I've seen is that not only are transportation needs diverse, but every person will have a diverse need of different types of transportation, depending on what happens to them. Even the same thing, if I have to get the radiation therapy every day for 6 weeks, I'm probably going to need multiple different means of transportation to fulfill that. So it is no one size fits all. That means it's got to be a diverse group of solutions, all linked together. I'm in a small city, much smaller than Austin, 80,000 people. The lower the population density, the harder this becomes. You get into rural areas, it's really difficult. Not enough people means the systems that are in place just can't be sustained. You don't have enough drivers, you don't have enough vehicles. I started out trying to build a transportation solution for under-resourced cancer patients. And I realized pretty quickly that if I did that, I would have an unsustainable system that might work for a little bit, but kind of like you mentioned, it would require money to keep going. If we solve transportation for the city, for all people, for whatever they need, then we can leverage that to fill whatever need we need. Cancer patients that are under-resourced and don't have the money for transportation. We have all these different systems in our town. They're so disconnected, nobody knows who to call. And so that's where the idea of a connectivity platform came from, because it doesn't matter whether you're talking about transportation or you're talking about housing, you're talking about food or whatever. It's how do I connect to the things that I need to live well? So why is healthcare such a big part of transportation? So while you can't build anything sort of within a healthcare system that's going to suit the community, at the same time, everything has got to tie back to healthcare, because that still is an incredibly important part of it. Not only is it a critical component, though, the system actually has the most to gain from all of this. So we've already heard these stats, and I've got the link in there. I think it's even higher. The health of the individual is much more dependent on the health of the community in which they live than the delivery of healthcare. 85 to 90% is the number that I use, and I think that it's even higher for folks who don't have a chronic disease. If you don't have a chronic disease, we saw many people with lung cancer develop lung cancer in their 70s and never been to a doctor in their life. They didn't need much healthcare system at all. The loss of revenue, this I think this exact stat was mentioned, $150 billion annual in no-shows. That's just the lights, being on and the doctor's office being empty. It says nothing about downstream complications from missing an appointment. So the healthcare system can get immediate financial gains from this, and that's important because they have to have those to be able to work with any kind of system. Transportation is core to poverty. It's core to a hospital's payer mix. That's what we call it, a payer mix. If you can't pay your bills because you don't have your money, then you're just a drain on the health system. Fix that. People have a job, they're happy, they have a better income and a better life, and now I can have health insurance and pay my bills. We're in a single health system region. So we have one, it's called Central Health. It's our only hospital system. It's actually worse for them. I used to think there was a real benefit because we could do all these things in the community because you didn't have to, the systems weren't competing. But in terms of this type of thing, if people in my community have transportation, they can easily get in the car and drive to some place that they think is a better health system. So you have this outflux of patients that are your paying customers, and it makes it really hard on a rural hospital system. They're also a major employer. They typically are in a rural area. So if you fix transportation as an employer, it also gets better. So this is kind of my graphic of what we've got here in our city. Whether you're an individual, whether you're a caregiver, or whether you're somebody who's just their situation has changed, you look out there, and these are all real systems in my community that many people don't know what 3/4 of them are, and they don't know how to access any of them. So how can we put this all on one network? So that's what I set out to do, is be able to put everything on one network. Now, this is not a network where we're leveraging market share for money. The idea is to put it all on one network so that everyone has access to everything, and all of those individual systems are interconnected and have access to clients. We're trying to increase the ability to connect a passenger to a driver for the benefit of both sides of that coin. And I break this down now. This has been really hard to get through people's heads. So I break it down into 4 groups: public transportation, workforce transportation, rideshare, and volunteer network. Everything of this is running in our city right now. Public transportation is the part where healthcare is a key component. The idea with all of this is you already have everything running, but you want to increase options that are available. You want to create ways that new sustainable transportation systems can be built. So if somebody has an idea, I really need to fix this solution, how can I build it? Okay, can we build that and sustain it by connecting those people to their clients? You got to maximize access. So for every person, you want to be able to make it easier for them to get to all the things that are available. And then very important is to reduce costs in all sectors. And one of the ways you do that is you keep the capital from going out of your community. Uber may be a solution for some, and that's fine. But every time you take that, 50% of the money goes to Uber. If you can keep it so that all the money stays within the community, you reduce the costs of that transportation in half. You also want to minimize insurance. You want to minimize risk and liability. I could go on about the Tesla Model X, but we're getting ready to kind of propose that as a public transit vehicle. It's a whole nother discussion that I'll have to blow over, but I'm just telling you that's the cool car for moving people around, I'll tell you. So again, one system, multiple tools. Public transportation needs to include non-emergent medical. You do that, and it's financially self-sustaining. Workforce transportation is a way to benefit both employers and employees so that they get to work. The rideshare, I'm really excited to tell you about a rideshare because it was built on watching Ride Austin, and it's really cool. I tried to filter out the profanity there. I'm pretty excited. And a volunteer network. The volunteer network is actually one of the most effective pieces, but public transportation serves its purpose, and there are needs there that have to be done in that way. Contracts with Medicaid, Medicare, different insurers. Workforce transportation, extremely important. This rideshare, potentially the most powerful piece of it because it's the lowest cost transportation system for your community. But a volunteer network is what fills in all the gaps. The volunteer network is how things get done that nobody else wants to do. When the liability is too great, but I can't do that. We're too afraid somebody's going to fall and get hurt. That's when a volunteer goes into the house, helps them get their stuff, helps them get in the car, helps them get there, helps them get into wherever they're going. So all these systems are critical. I'm going to go through them one by one. Let me be sure I don't overrun on time. I'm trying, doing the best I can. The ticket with public transportation is to put together the local government public transit system and the health system. It needs to be attractive to everybody, not just a safety net. We have $10 million annual in buses that don't do anything for anybody in our town. How can we make a system that you and I would use? If we're not using it, we're not interested in it, then it's not a good system for all. You capture the highest reimbursement, though. That's how we do things in healthcare. If I'm setting up a new surgery or a new therapy for cancer, the first thing I do is look to see who the payer is that's going to be paying me the most money, and I make sure that I can collect that money. That's non-emergent medical. But you set up a system so that you can do both non-emergent medical and also workforce transportation, education, shopping, activities, leisure, whatever it is, you just pay for it all with prioritized non-emergent medical. You hire drivers so they're not fighting for customers. And again, you try to make it attractive. There was a mention of being in Portland. Sorry, I forget who says, and having good transportation. The younger generation doesn't want to drive. If we build good public transit, they'll use it. And that means it's going to be a more sustainable system. Real quick, workforce development. The federal government allows you to subsidize as much as $270 per employee per month outside payroll. You can't do it if you don't have a platform to put the money into. This gives them a platform where they can say, just like a medical expense account or paying for your health insurance, they can say, you can elect to have as much as $270 of your paycheck put into a fund. And that fund can be used for transportation. And because we have a digital platform where we can prove that transportation was taking them to work, any part of that system that you want to use for that money to pay for them to get there, that can be utilized. So now when Bob wants to drive Tom, or when Tom wants Bob to drive him to work because he wants to carpool, he can pay him, and he can get paid outside of payroll and without being taxed as he does that, which again increases the effectiveness of your money. And now it's worth it to carpool to work, where right now it's just not. I'm going to kind of skip through this. There's other incentives to making that sort of work. This is the thing we have that I think is potentially the most powerful. So we built a true rideshare network. So it's not a transportation network company. It's not a taxi company. It is a true rideshare, and that it is a closed, private, community friends network where you can come, and if you have an interest in transportation, this is a way to ask around and see if someone might be able to help you. We have rules of conduct. It's got to be locally moderated. That way we know if somebody's not doing what they're saying or trying to take advantage of people, we can get rid of them. We have a digital background check. The company is called DigiSure. It's an excellent product. We have ID verification for passengers so that everybody knows who everybody else is. No taxi drivers, no advertising. And because of these things, it's just one person asking the other one, hey, can you give me a ride to the airport? It doesn't affect your licensure or regulations on your vehicle. It doesn't impact your personal insurance. There's nothing wrong with me asking you to drive me to the airport and saying, hey, it's 3:30 in the morning, I'll happy to throw you 20 bucks. We don't take any money from anybody. So again, it's not a transportation network company. It's simply a platform to connect people together so that they can do this. We know this works. This is the way Uber and Lyft work, except they take 50% of the money and this doesn't. They have insurance implications. They have regulatory implications. This doesn't. They're nationally sort of regulated, trying to do everything for your city, which is what Ride Austin tried to fix. This is locally managed so that you say how this is supposed to look. You can't use it for official contracting thing, right? You're never going to be able to take Medicaid or Medicare payments. So it's just one piece of it, but very powerful piece. And again, a volunteer network works exactly the same way. Digital platform connects people together. You can use the same background check across the entire system. You can do ID verification, but mostly you have nonprofits be the gateway. And we're doing this a lot. where we have Meals on Wheels or different nonprofits, Park View Mission, Big Red Bus, we, listed nonprofits, and they'll tell us, hey, I've got a client that needs transportation. And then the volunteer drivers know this is a legit request. This is not just somebody that wants to get the dinner and they're cheap. This is somebody that genuinely needs transportation, and we can do it for whatever it is. We're not limited in our scope. And again, this is the piece that fills in the gaps that are really difficult. So how does it work? From the very beginning, I knew that you have to have a tool that people don't have to be able to use a smartphone or can't use a smartphone, don't have a bank account, all that stuff. They don't need the tool to be able to benefit from it. So we do a ton of our transportation by proxy, whether that's a family member, a caregiver, social worker, nurse, school person, well, it doesn't matter. They enter the ride and for the other person, and we can keep track of everything. They can manage that trip. So the elderly parent, this came about when my father got dementia, and he didn't want to lose his independence, but he just couldn't be driving. When you enter that ride request, whether it's you doing it for yourself or for somebody else, it basically is distributed to all the different networks that you participate in. So if you are a college student and you have a college network, if you're a patient in a particular hospital system or insured, it will go to those networks, and will also do that in the way that is specific to that network. So for instance, if you're a citizen of the city, you may interact with public transit at a different rate than someone who's a guest, because you pay taxes in that city. And then we can set up all that depending on the needs of that particular organization. It's this integration of multiple networks that is the piece that's very unique to what we have and what we're actually patenting. We're not patenting it so that we can make money on it. We're patenting it because we don't want somebody else to do it, because it needs to be just one network. Think about Bluetooth. What we've tried to build is the Bluetooth for your community. If you had different Bluetooths and you're like, oh crap, do I have Bluetooth or pink tooth? If I have pink tooth, and it's not going to sync up, right? That doesn't work, because it's all Bluetooth. It all works, all the Wi-Fi, it all works the same, right? So you want it to be one network. That's why we're seeking to patent. Transportation costs, we minimize those across the entire system. You could do things like as you get suggestions for rides, and we don't match anybody to anything. It just shows you the options. It can prioritize those based on cost, for instance. And what it's shown to you from that particular driver is also at the lowest cost for that driver, depending on your connection to them. And we can prioritize things like non-emergent medical, one, because it funds the system, and two, because those are still really important appointments, argue, but at the same time, getting to that park, getting to that kid's activity, those are still extremely important to life, and arguably more important sometimes. So this is kind of more of a schematic of what it looks like, what we can do with it, where one portal of entry can get you to all these different systems, and you can build just numerous different things that you kind of want to have now, but you just don't know how to put them together. So what's the next steps? So this is what we're actually doing in our town now. We're assigning different groups to these different pieces. So it's the health system. I finally, like 6 years of fighting, I have the health system and our local public transit. We're getting ready to work on a pilot, a microtransit pilot. We could probably get state funding to do that, but genuinely it will be financially self-sustaining. The Economic Development Office is looking at the workforce, being an advocate for the workforce platform, so that any employer can do that. Although our health system may end up being a driving force simply because they're like 10% of our population. The rideshare, again, we're going to start expanding and sort of building on this. It's utilization that makes it work. If nobody asks for rides, then drivers, you're kind of like, why am I here? And as well as the volunteer thing. So we're going to the nonprofits and saying like, look, hey, push out to your drivers to get people on board. The guy I'm partnered with that has another piece of technology that eventually you guys are going to hear about that's really cool. He was telling me last week, he is part of a network for the Children's Hospital in Charlottesville, and maybe twice a year he helps with a family that has some sort of transportation need. That's the kind of thing that we can do on a national level, where you can be on a volunteer network and see occasional needs. You don't have to do something every day. You don't have to quit your job to do this, but every once in a while you may find something that you realize you can really help and make a difference with. One other thing I mentioned that I also stole from Ride Austin is what I call volunteer mode. And so as a volunteer driver, I can drive people around for money, like on Friday night, I can take people to restaurants and whatnot. But in volunteer mode, the money goes into a central account. It basically is raising money for transportation needs for under-resourced within our community. And then we can use our community foundation to help distribute that. And we can even set those people up with an account so that they can have a direct debit on that to get where they need to go. Last thing is that our company, because these things are difficult, getting people to do things new is really tough. Our company is probably going to become what I call a dumping ground. So for instance, public transit is probably going to be in an alignment between our health system, the Greater Lynchburg Transit Company, which is our bus company, which is owned by the city itself, and our company. And what that means is when they say like, I don't want to own that car, or we can't buy that car, we'll own it. If they say, I don't want to take on that liability, we'll say, okay, we'll do it. And we're already doing this. Like we have someone assigned. If the free clinic needs transportation for a person, but they say like, I can't do this ride share thing. They send us a ride request. Hey, here's our patient. Here's where they need to go. And we have somebody that basically accesses those networks and finds them transportation. And that way the free clinic can say like, I send it to you. And we're a nonprofit for transportation. And we can go, yeah, we'll do it because we're going to get it done. And we defer the liability from them because they're always terrified they're in healthcare. But we can coordinate all these things, use of the technology. That's unfortunately our generation. We're not good with tech. And when I say that, I don't mean we're not good at coding. I mean, like we have trouble using apps. So teaching people how to use apps, training restaurant owners of how to use things, registering volunteer drivers, helping them understand how to use the app, maintaining this rideshare network locally. And then ongoing, what's really helpful is us being the software developers themselves. We continue to tweak the software as we use it and implement it. And that's why we're really hoping to be not just partnered with Livestrong, but provide this technology to all of you. Let me tell you, all of this is ready to go. I'm not here to sell you anything. If any of you want to try to implement this in your community, please contact me. That's desperately what we want to do. Where our value is going to be is from becoming a solution for that health system. And then we can sell things back to the health system. Plus we have another piece that, as I mentioned, is going to be, all right, we're building a fully patient-centric electronic medical record. And specifically for cancer patients, from the start, it's called LARX, L-A-R-X. And you will be able to control your entire medical record. And I don't mean that it's not a little app. It's the real deal. And we're looking at being able to turn everything around on its head. And that's true patient centricity right there.
John,
So that's where the money will come from. We're not worried about this. So thank you for your time. Like I said, it's a long time coming.